Hi, my name is Dr. Anthony DeMarco. I would like to talk to you today about office-based anesthesia. In this talk, I want to describe to you my journey from working in a hospital setting to gradually going to office-based anesthesia. I found that working in office-based anesthesia for me was much more rewarding and the lifestyle was much easier. My background. I went to college for 5 years at Beaver College, which is now Arcadia. After Beaver College, I went to medical school at Kansas City Osteopathic. I finished my medical school in 1989, and from 1989 to 1999, I did a rotational internship year at Fitzgerald Mercy Medical Center in Delaware County, Pennsylvania. After doing my rotational internship year, I spent 3 years in my residency at Hahnemann Hospital learning and performing general anesthesia, IV sedation, regional anesthesia, and I spent 6 months performing cardiac anesthesia. And in those days, from 1990 to 1993, we were doing a lot of cardiac surgery, open heart surgery. And at Hahnemann, we were doing 6 to 8 open heart surgeries per day. So we got a lot of cardiothoracic anesthesia at Hahnemann Hospital. Also, in my 3rd year, I spent 3 months performing pain management at a local cancer hospital. After I finished anesthesia in 1993, it took me 2.5 years to get my boards, and after graduating anesthesia, I went to Methodist Hospital where I achieved my boards in 1995. Spending 9 years at Methodist Hospital, I became more proficient at anesthesia, but not also becoming more proficient. I started to think about different ways of improving some of the systems that we were using in anesthesia. One of the things I was thinking about, one of the procedures that we were doing, I noticed that we were doing them in the hospital, and I thought they could actually be done in an office. Specifically, cataracts I thought could be done in the office. What actually happened was they just started performing cataracts in a smaller hospital called a surgery center, and eventually places did start to provide office-based anesthesia for cataracts, probably from 2010 on. One of the things at the hospital that I noticed was that procedures, patients, the way they were treated were kind of like a hospital, and we were rushing and we were trying to get our cases done. And I felt that we need to try to improve patient care at that time, and I really was thinking that, looking at a hotel, we should be trying to provide that level of care to our patients. And with office-based anesthesia, I noticed that we could do that. In 2000, the medical industrial complex started to cause problems for individual physicians. We were having difficulties getting malpractice, And at this time in 2000, hospitals were then taking over medical practices in order to pay for physicians' malpractice. I was concerned. I started working against this problem. It was the malpractice crisis that we were trying to solve, and unfortunately nothing really happened. The hospitals took all the physicians over, and malpractice was paid through the hospital. I was worried about the hospital, Methodist. It was a small hospital. I was worried that we were going to be closed. So in 2002, I went back to Hahnemann Hospital, where I did my residency, and became director of same-day surgery there for only 6 months. I really did not enjoy it. It was the same as what I came from, a hospital setting. But I thought going there, I could potentially improve patient care and give patients more individualized care doing same-day surgery. That did not happen, and I felt like I was still looking for something different. And in 2003, I joined a group called Anesthesia Advantage. At that time, they were doing colonoscopies in the office. And I thought, this is what I want to do. I want to do something that it was individualized for each patient. Patients felt more comfortable in the office because they knew the office. And I thought we could give actually better care, more efficient. These offices were run by physicians and nurses, so we knew how we wanted to run it versus the healthcare systems, which were being run by CEOs and vice presidents. So from 2003 to 2006, I worked in office-based anesthesia doing colonoscopies. At that time, I thought, this is something that I would like to do and become an independent contractor and do this on my own. So in 2006, I started my own company called Mobile Anesthesia Service Concepts. And the office-based anesthesia that we did in that day was, I continued working with some gastroenterologists doing colonoscopies, but I also joined my wife, who was an oral surgeon, performing wisdom teeth under general anesthesia. So what we would do is we would take teenagers, they would come into the office, I would put them to sleep through a mask, so they would breathe down anesthetic, put them to sleep. We would start the IV after the patient was asleep so that they wouldn't feel a needle. And this is how we do the procedures today. So our adolescents don't feel a needle, and they feel more comfortable and less stress coming in and getting their wisdom teeth out. But I also did IV sedation for colonoscopies. In 2007, one of my wife's friends asked me to do anesthesia for a dental procedure. She was placing an implant. And I said, sure, I'll do that. We just need to get the medical insurance so that we can charge the anesthesia to the insurance. Well, we did. We looked up the insurance, and the medical insurance would not cover the procedure. And so they asked us to look at the dental procedure, but that didn't work either because we are not dentists, so we can't take dental insurance. So what happened was, this was a cash case. Never dealt with a cash case before. All the cases I dealt with was insurance. So I was thinking, okay, what am I going to do? How am I going to handle this? Well, I knew anesthesia was a time payment. We would charge patients every 15 minutes. And so with my wife, who was doing anesthesia also in the office. She was an oral surgeon, but she also did anesthesia. They would charge cash for their procedures at times when dental insurance didn't cover it. And we devised a fee for every 15 minutes. And we also devised a fee for the equipment we used. So this was the first cash case I did. And I realized, wow, okay, so now I can do wisdom teeth, I can do colonoscopies, and now we can help dentists with patients who are afraid of the dentist getting dental procedures, and we can put them to sleep for this. So my idea was, let me pack up my car with all the equipment that I would need in the office. So I would bring the operating room to the office. So we would come in, we would pull up, go into the office, set up the anesthesia so that we could do the anesthesia case in the office, put the patient to sleep, allow the dentist to do the procedure, and then wake up the patient, and in 60 minutes let the patient go home. We also tried to do this for pediatric patients. Again, we did general anesthesia. We put the patient to sleep first, start an IV, intubate the patient, and then we would do dental rehab for patients that were ages 3 to about 14 years old. So the master plan was, I really didn't have a master plan. What I found was that I could actually charge cash for procedures in the dental office, which was, one, helping the patients that were really afraid of the dentist having dental procedures, and also helping the dentist be able to do the procedures. Unfortunately, in 2018, Medicare dropped the reimbursements by 31%. So at that time, we no longer did colonoscopies. So mainly, we continued just working with dentists. And by getting more and more dental offices, the ratio of cash to insurance was about 80 to 85% cash to 15 to 20% insurance that we accepted. So this was better. I was making more cash than insurance and providing a service for patients that were afraid of the dentist. The great thing about doing office-based anesthesia and being an independent contractor was there was no calls. So I could spend more time with my kids, my family, and be off for holidays, which was wonderful. The nice thing about doing office-based anesthesia is you are making cash, and this helps with you're not waiting 6 to 8 weeks waiting for reimbursements to come in. We were getting immediately paid for the procedures we were doing. It was less stress because I did have other people working for me, so I could pay those people every 2 weeks. Is money important in your life? Yes. Why? Because it helps support your family. You can save for your retirement. You can enjoy your life more. This is the life we deserve. I mean, think about how much education you spent trying to get here. You spent 12 years of going to elementary, middle, and high school, 4 years of undergraduate school, which was very stressful because you had to get all A's, and you had to do really great in the MCATs in order to get into medical schools. And once you got into medical school, you weren't done taking tests. In the first couple of years, you had to pass your national boards. And in Pennsylvania, for osteopathic physicians, we actually had to pass a third board. After residency, spending 4 to 6 years in anesthesia residency, you spent a year and a half to 2 years trying to pass your written boards and then also your oral boards. So who makes more money? Paid employees of the health systems or independent contractors? I would say at this date in 2026, it's very similar to making money. The nice thing about independent contractors is they can set when they want to work, when they want to be off, when they want to be with their family. Who works harder? Definitely employees of the health systems work way harder because independent contractors can set how they want to work. Just food for thought. And that's why it's nice to be able to not only make money through health insurance, but also making money and that my entrepreneurial practice can make cash, which enables me to pay my independent contractors quicker, and that we have better cash flow. Thank you for listening to this presentation.